Hello there and good afternoon. My apologies as I've had a family emergency and while I just saw you this morning, I unfortunately had to emergently take off. But I wanted everyone to hear a lot of the updates, if you will, of that we have in terms of imaging, whether that's whole body MRI and certainly exciting innovations in PET CT imaging as well. So relevant disclosures for this is that I'm a active investigator for both Clarity Pharmaceuticals as well as Blue Earth Diagnostics. And so again, I think everyone in this room is familiar with the fact that the imaging for prostate cancer in terms of staging as well as biochemical recurrence has evolved over the time. And what used to be more of an unclear picture has really become a lot more refined, and the light has been really shined on certain areas so that we can better localize where that disease is as well as where it's recurring. So that evolution has gone from bone and CT scans to choline PET scans to now PSMA PET CT and possibly combinations of all of this. And again, just to reiterate that the old standard using CAT scans were really inaccurate. They couldn't pick up small, metastasis less than 1 centimeter. And so certainly that's not getting anywhere close to microscopic evaluation or limitations, and certainly can't pick up things that we can with a lot of the other technologies. And again, to get a positive scan, men usually had to have a PSA that was greater than 20. And so again, it's not really that useful, but that used to be that gold standard, as well as bone scans. And again, we're all very familiar with it, is that was the gold standard, but there were many problems with it. Again, had to have a high PSA to get a positive results. And it was complicated by the fact that many other things other than prostate cancer could give you false positives. So prior trauma, injury, et cetera, can all come up that looks like possible metastatic disease, but really wasn't. And so within recent years, whole body MRI has really started to come into play, and people have asked to say, can we do whole body MRI? And again, I'm not talking about multi-parametric pelvic prostate imaging. I'm referring to scans without contrast that are scanning a patient's entire body. And again, this is very appealing because, again, we know that compared to conventional imaging with CT and bone scan, we know it has improved diagnostic capabilities. There's a lack of radiation exposure or lack of concern about gadolinium. And so this is exciting for many patients because we're not increasing their risk of either renal dysfunction or other radiation exposure problems. And certainly you can replace both CT and bone scan with this. So it's replacing two with potentially one. And compared to PET scans, there's no need for radionucleotide production infrastructure. So getting an agent in a certain time isn't relevant. So that helps there. And certainly from a cost perspective, most facilities these days have their own MRI facilities. And again, people have evaluated this and compared to CT or really multiparametric pelvis imaging in men with hormone refractory prostate cancer, the sensitivity of these of whole body MRI is superior compared to either of the more historic technologies as well as the increased specificity. So I think we're starting to see a lot of this, and many studies, this isn't just a one-off, but this is many studies and certainly a meta-analysis has been conducted really showing that it has potential utility here. And again, in more recent years, people have compared whole body MRI to PET CT imaging localization for identifying metastatic disease, both in the hormone sensitive and hormone refractory spaces. And again, looking at a meta-analysis, they have approximately similar sensitivities, and there was no real difference in specificities. Again, demonstrating that may be a useful adjunct to some of this imaging. Some of the studies suggest that maybe whole body MRI was a little bit more sensitive, but again, comparing to the gold standard is always a question. But I would say at simplest, there has a lot of potential here to identify metastatic disease. That whole body MRI has potential. So what are some of the updates in PSMA PET CT imaging? I think I covered some of this of what's new is that we've really seen an evolution of the radio tracers that have been utilized. We've really gone from FTDG PET, which is really not specific for prostate cancer. Every once in a while, you will still get a referral from MedOnc saying, hey, we imaged this person thinking it was lung cancer and the prostate lit up a little bit. So it's not completely futile, but that's certainly not the mainstay. Choline was the next generation, and then flucyclovine, the Axumin type scan, which was taking advantage of the amino acid transporters. Somehow that's not used. I argue there still may be some utility there. And then into kind of the modern era in the past, 5 years, that PSMA has really dominated that scene. And again, whether that's a gallium based or F18 or certainly more copper based, which are the most recent, that these signals that we get are certainly promising for the localization of prostate cancer along that prostate cancer journey. So I think that this was covered yesterday a little bit, but there has been FDA has approved many different agents in terms of their utility for prostate cancer imaging. Again, I think the point here is that we have all seen and the studies have supported that we've been able to localize disease with higher sensitivity and specificity compared to conventional imaging, and even among each other. We still don't know if there are any superiority between any of these agents. And again, I think seen yesterday that in the initial staging, as well as the biochemical recurrence population, is that all of the agents that are currently available are basically, with some subtle differences based on study design, appear to be very similar in terms of sensitivity, specificity, and overall performance. Again, I think a lot of this will kind of be highlighted in question of if we can localize certain areas of the body, whether that's the prostate bed after prostatectomy with some of these agents a little bit better based on how they're processed, will be highlighted over studies in the next few years. Again, also in the biochemical recurrence space is that there is a similarity between all of the current available PSMA agents. They have an overall equal appearing sensitivity and specificity. Again, none of these are really able to get to our goal, which is to really beat the microscope. But these are getting closer and closer to identifying this. So as an example, it is believed that most of these agents will be able to localize about a 4 millimeter lymph node. Again, very impressive compared to the historic gold standard, which was about a centimeter in size. So we've really moved that bar. But where are we going? And I think some of you also heard me talk about this yesterday, but there are newer agents that have been and continue to be developed. The latest is a copper 64 PSMA agent, which again distinguishes itself because there are two potential binding sites. These appear to be stronger, and the longer that this radio tracer is incubated with cells, the stronger that signal gets. And certainly the next day imaging of these patients appears to be even brighter and more defined, which again makes it easier for us to see. The propeller study of the copper agent really highlighted the fact that on the second day that we were able to see more lesions that were present. And the reason why, again, that's important is identification of the true extent and localization of the disease is so important in terms of coming up and formulating a treatment plan that is truly appropriate, whether this is oligometastatic or not oligometastatic disease, the number of lesions, and the type of and duration of systemic therapies. And certainly, if you can do a focal therapy to just a solitary lesion or two will be better defined the more we can see this. So again, I think that this is an exciting improvement in the overall PSMA imaging space that we will certainly see over time. And again, when you look here is that on the second day, there are higher SUV maxes, easier for us to see and develop those treatment plans. But again, all of this is great, but the question is, are there differences based on these type of radio tracers? Which one should we or should we not be using? I think we don't really know. But I think, it is important to highlight these differences and try to understand why these agents light up things differently. So this study really compared the copper agent to the kind of more historic choline-based PET CT imaging scan, and the ability to localize cancer in various areas based on whether it was a PSMA or a choline was very different. And again, it's not that one is necessarily superior at this point, but on the other hand is certainly what we're trying to understand are the differences in biology that may drive this. And so people have started to look into this. And some people have said that the ability for us to detect or have an avid lesion on a PSMA scan may be related to the growth patterns of the tumor itself. And so there are various patterns that you can see that will light up and those that will not light up based on the actual inherent biology of those tumors. And again, other people have looked specifically and they used a decipher assay. And they said, well, who is going to have a positive scan and who's going to have a negative scan, an avid or negative scan? If you compare PSMA to flucyclovine, the Axumin type scan with the amino acid transporters. And as we see, as there's variable expression of the targets within these type of tumors based on the radio tracers used. So what I mean by that is that the biology of the tumor will express certain molecules, whether that's PSMA or amino acid transporters, very differently. And based on that differences, that theoretically you will see a difference in the scanning outcomes or the detection targets that we see. And so this particular study really highlighted that there was a comparison that those with high amino acid LAT3 transport expression did better than those compared with low amino acid expression. But if you are considering doing a scan with the Axumin in that, you would actually detect more patients who are going to have better outcomes versus PSMA. When you look at that expression, that was the exact opposite. So those with higher PSMA tended to do worse, and theoretically the targets would light up more. So potentially that type of tumor would be more amenable to a PSMA. Again, these are things that we are learning over time of the biology driving what is going to make a scan avid. So I think, the summary here is that there have been many advances in imaging that have occurred really over the past several decades. Nothing still beats what we can see in the microscope, but it is really our job to come as close to highlighting those lesions so that we can, in the smallest number or smallest size of those lesions as we can, so that we are coming pretty close to that microscopic image. Again, the whole body MRI has some potential and certainly has some advantages because of the cost, the radiation, there's no contrast that is used. So we're looking forward to seeing how that contributes to the space. And certainly PET imaging has really become the new gold standard for identifying where that disease is. But again, trying to understand the biology, which is driving the PET imaging, is very important. And certainly we will see more of that. And as we understand more, it will highlight and make these studies even better. And as I said yesterday, perhaps in the future, we will be using a combination of radio tracers to really identify the true extent of tumors. So I think I'm really excited to see where this is going. And certainly it was a pleasure being invited to this conference and look forward to seeing you guys next year.